The heart has mainly three surfaces: the anterior surface, the inferior surface, and the posterior surface. Those are the three main surfaces of the heart: the anterior surface, the inferior surface, and the posterior surface. And the anterior surface is also known as the sternocostal surface because it is facing the sternum and the costal cartilages. The inferior surface is also known as the diaphragmatic surface because it is sitting on the thoracic diaphragm. And the posterior surface is also known as the base because it is opposite the apex. And when you look at a pyramid, the side which is opposite the apex in a pyramid is known as the base. So because the posterior surface is opposite the apex of the heart, it can also be known as the base. The other point about the surfaces of the heart is that we must know the different chambers which form the different surfaces of the heart. So the surface which is facing the sternum is known as the anterior surface. The surface which is sitting on the thoracic diaphragm is known as the inferior surface or diaphragmatic surface. And what we are not seeing, which is hidden at the back, it is opposite this apex, is known as the base or the posterior surface. So we are going to peel away the pericardium to look at the chambers which form the anterior surface. So the anterior surface is formed by this chamber. This chamber is known as the right atrium. The right atrium is this chamber. It's one of the chambers which form the anterior surface. And this region where you have blood vessels and fat, this margin here, or this region here, is what we call the atrioventricular groove. The atrioventricular groove. A groove is a depression. And in this case, this depression known as the atrioventricular groove, it is because it's between the atrium, right atrium, and the right ventricle. So because it is between the right atrium and the right ventricle, we call it the atrioventricular groove. So we have the right atrium and the atrioventricular groove. Then we have the right ventricle. This is the right ventricle. And then there's another region here known as the anterior interventricular groove. Why do they call it interventricular? Because it is between two ventricles. Why do they call it anterior? Because it is on the anterior surface. This is the anterior interventricular groove, and it also contains blood vessels and fat. And then this is the left ventricle. So what forms the anterior surface of the heart, or the sternocostal surface of the heart? We have the right atrium, the atrioventricular groove, the right ventricle, the interventricular groove, and the left ventricle. These are the chambers which form the anterior surface of the heart. Of course, if you want to know that when blood enters the right atrium through the vena cava, it goes to the right ventricle. Then the right ventricle pumps it into the pulmonary trunk to go to the lungs for oxygenation. So, right atrium, atrioventricular groove, right ventricle, interventricular groove, left ventricle, anterior surface of the heart. The same applies here: right atrium, atrioventricular groove, right ventricle, anterior interventricular groove, left ventricle. This we have oriented the heart so that we see the surface which sits on the diaphragm. This is what we call the inferior surface. It's the surface of the heart which sits on the thoracic diaphragm, and it's also known as the diaphragmatic surface. So this surface is made up of the left ventricle, the right ventricle, and a groove between them with blood vessels known as the posterior interventricular groove. The left ventricle, the posterior interventricular groove, and the right ventricle, and also the inferior vena cava. So these are the chambers which form the inferior or diaphragmatic surface of the heart. Left ventricle, posterior interventricular groove, right ventricle, inferior vena cava, they form the inferior surface of the heart. Then the posterior surface of the heart is this one, which we are not seeing when you look at the heart from the anterior. The posterior surface of the heart is formed by the left atrium and the 4 pulmonary veins which are bringing back oxygenated blood to the heart, 2 on the left, 2 on the right. So the posterior surface or the base is made of the left atrium and the 4 pulmonary veins entering into it. Those are the surfaces of the heart. Some textbooks will also give you the superior surface, which has great vessels, but the major ones for me I'm talking about are the anterior, the inferior, and the posterior. And I say that the posterior surface is also known as the base because it is opposite the apex. And you also have to appreciate that the right ventricle and the left ventricle participate in formation of both the anterior surface and the inferior surface. Because after forming the anterior surface, they go to the inferior surface and also participate in formation of the inferior surface. The apex of the heart is in the left ventricle. Then the heart has boundaries or borders. That is the right border. Then it has the inferior border. Then it has the left border and has the superior border. Let's go back and look at those borders. The heart has the right border, the inferior border, the left border, and the superior border. Borders are margins or boundaries. Surfaces are faces. The right border is formed by the right atrium. The right atrium forms the right border. The inferior border is here. It is formed by the right atrium on the extreme right, the right ventricle in between, and then the left ventricle. Most of it is formed by the right ventricle. Its left extremity is formed by the left ventricle, and its right extremity is formed by the right atrium. So right atrium, right ventricle, left ventricle, they are forming the inferior border. The left border is formed mainly by the left ventricle. As you can see, this chamber is the left ventricle. So the left ventricle is forming the left border, plus that part of the heart known as the left auricle, and we shall see what the auricle is. So the left border is formed by the left ventricle and left auricle. And the superior border is formed by the beginnings of the great vessels or the roots of the great vessels. The great vessels will have the superior vena cava, aorta, pulmonary trunk, and then the pulmonary veins. So the roots of the great vessels are the beginnings or are their attachments onto the heart. So when you look at the superior border, it's made by the roots of the great vessels. From the right, you have the vena cava, aorta, pulmonary trunk. So we have finished the borders also. Right border, right atrium. Inferior border, right atrium, right ventricle, left ventricle. Left border, left ventricle and left auricle. Superior border, roots of great vessels. Those are the borders or boundaries of the heart. And the borders, I've mentioned them and what forms them. So you can even superimpose these borders on a chest X-ray. When you see the shadow of the heart, the right border is there, the inferior border is there, the left border is there, and the superior border is there. And the right border is formed by the right atrium. Inferior border forms the right atrium, right ventricle, and left ventricle. So right atrium, right ventricle, left ventricle. The left border is formed by the left ventricle and left auricle. Around there you have the left auricle. And the superior border is formed by the roots of the great vessels. Superior vena cava, aorta, pulmonary trunk. And around there we'll have the atrioventricular groove between the right atrium, right ventricle, and then the anterior interventricular groove between the right ventricle and the left ventricle. It can give you an idea of where the different chambers of the heart are located. If you have done the surfaces and the borders, you can estimate where the great vessels are, where the chambers are. And this is our thoracic diaphragm, where the heart is sitting. And you can see that this heart looks like that. And even when you open or when you dissect away the anterior wall and look at the inside aspects of the chambers, you clearly see it properly. So you can see the right atrium, the right ventricle, the left ventricle. The left atrium is posterior. We have just kind of brought it out so that you see that it also exists. And you can see the right border, the inferior border, the left border, and the superior border. And you can clearly see that the apex of the heart is in the left ventricle. And the wall of the left ventricle, you can see proportionally it is thicker than the wall of the right ventricle because it needs a greater force. The blood coming from the left ventricle is going to go to the rest of the body, whereas the blood coming from the right ventricle is only going to the lungs. So blood, we can see blood entering into the right atrium, which is deoxygenated, coming from the lower extremities through the inferior vena cava and coming from the upper extremities through the superior vena cava. And the rest of the blood entering the right atrium is coming from the heart itself, because the heart also has deoxygenated blood, as we shall see. Then it is pushed into the right ventricle through the tricuspid valve. Then the right ventricle pushes it into the pulmonary trunk through the pulmonary valves, and the pulmonary valves are semilunar. After the blood goes to the lungs, because the pulmonary trunk is going to divide into the pulmonary arteries, it will go and receive oxygen and come back to the left atrium through 4 pulmonary veins, 2 on the left and 2 on the right. From the left atrium is pumped into the left ventricle through the mitral valve or bicuspid valve, and the left ventricle pumps it into the aorta through the aortic valves, which are semilunar, and the aorta distributes it to the body. So this is the proper representation of our heart, showing the right positions of the borders and how the chambers connect with each other. Surface markings of the heart are very important when you're listening to valves sounds. And now this point is very important. I'm going to run through it. That's why you must be very, 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 very attentive. A surface marking is whereby you can mark on the surface of the body where a part of the heart is located, even without opening. Now, these black points indicate the regions below which you have the valves. The black points indicates the regions below which we have the valves. Now, The pulmonary valve is below the third left costal cartilage. It is below the third left costal cartilage. Very important. Below this point, that is where you have the pulmonary valve. Below the third left costal cartilage. So when blood is moving from the right ventricle to the pulmonary trunk, it moves like that. From the right ventricle to the pulmonary trunk, blood moves like that. So the pulmonary valve is below the third left costal cartilage. Where can I listen to its sound? From where can I listen to its sound? You cannot listen to its sound on top of cartilage because cartilage may obstruct that sound. You have to go to the nearest intercostal space in the direction of blood flow. You have to go to the nearest intercostal space in the direction of blood flow. Because in the intercostal space, we only have soft tissue, we don't have hard tissue, so you can easily listen to that sound. The hard tissue is not there to obstruct it. So what is the direction of blood flow? Through the pulmonary valves. Blood moves like that. From the right ventricle to the pulmonary trunk. Blood moves like that. So where is the nearest intercostal space in the direction of blood flow? It is there. That is where you auscultate. To auscultate is to medically listen to. That's where you auscultate. And there is an instrument known as the stethoscope. So that's why you auscultate the sounds of the pulmonary valve. In the second left intercostal space adjacent to the sternum. And where is the valve? Deep to the third left costal cartilage. The aortic valve is there. The aortic valve is deep to the sternum. The aortic valve is deep to the sternum at the level of the third intercostal spaces. At the level of the third intercostal spaces. Deep to the sternum at the level of these are the third intercostal spaces. So it is deep to the sternum at the level of the third intercostal spaces. So when you open the sternum there and you go deep, you find, and open the heart, that's where you find the pulmonary valve. The aortic valve, not the pulmonary, aortic valves. How does blood move through the aortic valve? Blood is moving from the left ventricle and it's going to the aorta like that. So it is moving like that. So where is the nearest intercostal space in the direction of blood flow? It is there. So you can auscultate the sounds of the pulmonary valves in the second right intercostal space adjacent to the sternum. This intercostal space, as I said, there is no hard tissue, so obstruction of sound is not maximum. You can easily auscultate it. Remember, blood in the pulmonary valves moves like that. You auscultate there in that intercostal space. Aortic valve, it moves in that direction. You can auscultate there. You auscultate a valve sound in the nearest intercostal space in the direction of blood flow. This is our tricuspid valve. The tricuspid valve is deep to the sternum, adjacent to the right fourth costal cartilage. This is the right fourth costal cartilage. So it is deep to the sternum, adjacent to the right fourth costal cartilage, where the right fourth costal cartilage attaches to the sternum. At that level, below the sternum, you are having the tricuspid valve. How does blood move through the tricuspid valve? It moves from the right atrium to the right ventricle. It moves from the right atrium to the right ventricle, like that. That is how blood moves. If you go back to prove that, blood moves from the right atrium to the right ventricle. And also, so pulmonary trunk, it moves like that. And the aortic valve, it moves like that. So that is the direction of blood flow that we are talking about. It moves from the right atrium to the right ventricle, obliquely like that. So where is the nearest intercostal space in the direction of blood flow? It is there. And this is where you auscultate the sounds of the bicuspid valve. The bicuspid valve, also known as the mitral valve, is deep to the sternum, adjacent to the fourth left costal cartilage. Adjacent to the fourth left costal cartilage, deep to the left half of the sternum. And this one, the tricuspid, is deep to the right half of the sternum, adjacent to the fourth right costal cartilage. And how does blood move through here? It moves from the left atrium to the left ventricle. From the left atrium to the left ventricle. And this one, we usually use the fifth left intercostal space at the mid-clavicular line. What is the mid-clavicular line? This is our clavicle. A line dropping perpendicularly passing through the midpoint of the clavicle is the mid-clavicular line. Where it intercepts with the fifth intercostal space, that is where we have the apex of the heart. The apex of the heart is in the fifth left intercostal space, where it intercepts with the mid-clavicular line. Deep there, that's where you have the apex, also the sounds of the mitral valve. These are the regions below which you have the valves, and these are the positions where you can listen to the valve sounds from. And for the apex of the heart, this is the surface landmark. The surface landmark for the apex of the heart is also the same as the area for auscultation of the sounds of the mitral valve or bicuspid valve. The other name for mitral valve is bicuspid valve. So I have given you all these notes to tell you to give you the notes. What I've been talking about are all in these notes. And I said that the sites of auscultation are places where you can hear the heart valve sounds better. And I said the best place to hear the heart valves is not necessarily directly over the anatomical site where they are located. Valve sounds are ausculted where they are nearest to the chest wall or the intercostal space in the direction of the blood flow. And I said in order to access correctly the findings of auscultation, it is necessary to know the sites where the valves project onto the wall. And also find out where the sounds are best ausculted. And I said that The sites where you can auscultate or listen to the valve sounds are areas where we do not have bone or cartilage. And those are the intercostal spaces where you have soft tissue in the direction of blood flow. So these notes are very, very, very important. We can also outline the boundaries of the borders of the heart on the chest wall without opening the chest. The right border, the inferior border, the left border, and the superior border. A point within the second left intercostal space adjacent to the sternum, where we usually auscultate the aortic valve. And a point on the sixth right costal cartilage about 1.2 centimeters from the sternum, and a point at the surface landmark of the apex, the fifth left intercostal space at the mid-clavicular line, and a point at the third left costal cartilage, third left costal cartilage, approximately 1 to 1.2 centimeters from the sternum. And when you join these points, they will give you the superior border, right border, inferior border, and left border. Now let us enter inside the chambers of the heart. We saw how they form during embryonic life. Now let us enter inside the chambers of the heart, and we look at some of the features of the chambers of the heart. How do these chambers of the heart look like on the inside of the adult heart? And we are going to look at some structures which are very important for our identification. So when you dissect the heart or you cut it out, you're going to look at the inside of the heart, and you're going to see that the wall of the left ventricle is thicker than the wall of the right ventricle. Some of you, when you're illustrating the heart, you just illustrate without any proportionality. You illustrate the heart showing the wall of the right ventricle equal in thickness to the wall of the left ventricle. Then you have failed that point. It must be proportional. So we have made an oblique section through this heart to look on its inside. This is showing us how we have sectioned the heart. And then we open it up. Here we are seeing the interventricular septum, the left ventricle, and the right ventricle. We are also seeing the left atrium and the bicuspid omitral valve leading to the left ventricle. And on the other side, we are seeing the right atrium, the tricuspid valve, which is leading to the right ventricle. The aorta, we are seeing it clearly here, and the aortic valves, because they are the ones which connect with the left ventricle. They are the ones which connect with the left ventricle. Part of it is there, and part of it is there, because this is the left ventricle, and the right ventricle is there under that point. And we cannot clearly see the pulmonary trunk in this plane, but blood leaves through that opening. That's where we have the pulmonary trunk. So here we have the bicuspid valve, and you can see it has two cusps. And here we are seeing the tricuspid valve. We're having this one, which is attached to the interventricular septum. One of the three cusps, this one is attached to the interventricular septum. That's why they call it the septal cusp. This one. And then we have another cusp there, which is on the anterior, attached to the anterior surface. That's why they call it the anterior cusp. And then you have that one, which is the posterior. You go and look at these cusps, the three cusps. That's why they call it tricuspid valve. And you go and also look at these two cusps of the mitral valve. What are we seeing? What else are we seeing? You observe very carefully that from the walls of the ventricles, we are having pyramidal muscles. From the walls of the ventricles, we are having pyramidal muscles. Principally 3 on the right and principally 2 on the left. These pyramidal muscles are known as papillary muscles. They are coming from the wall of the ventricles and they are known as papillary muscles. Attached to their apexes or apices, are fibrous cords. These are fibrous cords which attach to their apices. And on the other side, these fibrous cords attach to the margins of the valves. So we have our valves, then the fibrous cords, and these fibrous cords are known as cordae tendinae, and I've indicated them in these notes, the spelling. And then they also attach to the apices of the papillary muscles, both on the right and both on the left. What is the importance of these papillary muscles? These papillary muscles pull the valves open and push them closed. They pull the valves open during diastole and they push them closed during systole. Why do these papillary muscles push the valves closed during systole? To prevent blood from regurgitating back to the atria. So during systole, when the ventricles are pumping blood into the pulmonary trunk and the aorta simultaneously, that blood is prevented from regurgitating back into the atria by these papillary muscles contracting and pushing these valves closed, such that the only route for the blood to go from the ventricles is the pulmonary trunk and the aorta. So the valves are attached to fibrous cords known as cordae tendinae, and the cordae tendinae are also on the other side attached to the apices of pyramidal muscles known as papillary muscles, which are coming from the walls of the ventricles. In principle, 2 are in the left ventricle because of the 2 cusps, and 3 in the right, principally because of the 3 cusps on the right. What else are we seeing? What else are we seeing? We are seeing that our papillary muscles on the right are smaller than our papillary muscles on the left because of the thick wall of the left ventricle and its strength. Stronger contraction, stronger and bigger muscles. The other point we are seeing is that the inside of the ventricles, parts of the inside of the ventricles are rough. These are the rough parts of the ventricles. You can see the rough parts of the ventricles. The wall, the inner lining is rough. The inner lining of the ventricle is rough. And I will say that these rough parts of the inner lining of the ventricles are the ones which came from the primitive ventricle. When you're looking at the embryology, you say that the rough part of the ventricles came from the primitive ventricles. and the smooth part came from the bulbous cordis. So whenever you see the rough parts on the inside of the ventricles, those are the parts which came from the primitive ventricles. They are rough. And the smooth parts came from the, above there you can see some smooth parts. The smooth parts are the ones which came from the bulbous cordis. And the atria also have rough parts. The rough parts came from the primitive atrium, and the smooth parts came from the sinus venosus. You can see the smooth parts and then the rough parts there. What do we understand? What do we mean by the word auricle? What do we mean by the word auricle? Because the right atrium is connected to the right auricle, and the left atrium is connected to the left auricle. What is an auricle? In fetal life, the atria were made of these auricles. So these auricles, when you see them, just know that they were the atria. They were the only atria in fetal life. So what you had in fetal life as the atrium was this structure known as the auricle. As development continued, part of the sinus venosus entered into the atrium. Part of the sinus venosus became part of the atrium. And when part of the sinus venosus incorporated into the atrium, a small part of the atrium was displaced up. A small part of the embryonic or fetal atrium was displaced up to accommodate the incorporating sinus venosus. So that small part of the fetal or embryonic atrium, which was displaced up because the sinus venosus was incorporating itself also into the atrium, became the auricle. So your heart has an extension known as the auricle, which shows us that this was part of the embryonic atrium, which was displaced up during development when the sinus, part of the sinus venosus, was incorporating itself into the atrium. That is why when you open the atrium, part of it is rough, and the rough part also continues into the auricles. That rough part came from the primitive atrium, and the smooth part came from the sinus venosus, which incorporated itself into the, part of it incorporated itself into the right atrium. So the auricle was a displaced fetal or embryonic atrium as a result of incorporation of the sinus venosus, part of the sinus venosus into the right atrium. And the areas which come from the sinus venosus are the ones which are smooth. The areas which came from the primitive atrium are the ones which are rough, and they also include the displaced part, which is the auricle. And they are also, all of them are communicating with each other. The auricle is non-functional in adult life, but it exists and communicates with the atrium because it was part of the atrium in fetal life. These fetal remnants, we talked about them, the fossa ovalis that was formed when the foramen ovale closed. The lower margin of septum secundum is what we call the annulus ovalis. So these are the fetal remnants which I talked about them and what they form. And here we are seeing the sinus venosus. This sinus venosus is very important. It forms part of the atria because part of it incorporated itself into it. The trabeculated part of the ventricles is the rough part. Whenever I say trabeculae, those folds which form the inside of the ventricles to look rough are known as trabeculae. So whenever they say the trabeculated part of the ventricles, those are the rough parts of the ventricles. They came from the primitive ventricles, and the smooth parts of the ventricles came from the bulbous cordis. And we also looked at the aorticopulmonary septum dividing the truncus arteriosus into the aorta and the pulmonary trunk. So here we are seeing we have opened, this is the right atrium. We have cut away the anterior wall of the right atrium. You remember right border, inferior border, left border, superior border. Right atrium is there. That is the tricuspid valve, and the left ventricle is there, and the right ventricle is there, then the left ventricle is there. Here you're showing, we are seeing our right atrium, the atrioventricular groove, the right ventricle. We have opened the right ventricle now. And then the anterior interventricular groove, and then we have seen our left ventricle. Right atrium, atrioventricular groove, right ventricle, this is the one we have opened, anterior interventricular groove, and left ventricle. You remember the anterior surface of the heart. Here we had opened the anterior wall of the right atrium. And here we have opened the anterior wall of the right ventricle. So when you open this wall, when we open, excuse me, when we open this wall to look inside the right atrium, this is what we are going to see. We are going to see the right atrium on the inside. It has a rough part, which is the anterior wall which we have opened. This came from the primitive atrium. And it has a smooth part, which came from the sinus venosus. This is the wall between the right atrium and the left atrium, which is posterior there. And you can see the fossa ovalis, where the foramen ovale was. You can see the upper margin of the septum secundum and the lower margin of the septum secundum, which is the annulus ovalis. And we can see the inferior vena cava, superior vena cava entering, and also other veins draining into the right atrium, as we shall see. Then when we open the right ventricle, we can clearly see our tricuspid valve bringing blood from the right atrium to the right ventricle. And we can see the papillary muscles attached to the margins of the valves by the fibrous cords known as the chordae tendineae. Now, I want you to be very observant on this. There is a muscle, because if this is our left ventricle, it means that this is the septum between the left ventricle and the right ventricle. There is a muscle between the interventricular septum, which goes and attaches to the base of the anterior papillary muscle. This is the anterior papillary muscle because it is attached to the anterior wall. This muscle, cardiac muscle, comes from the septum, interventricular septum, and comes like that and attaches to the base of the anterior papillary muscle. You can see it there. From the interventricular septum, it comes and attaches to the base of the anterior papillary muscle because it's the muscle attached to the anterior wall of the right ventricle. Now, this muscle is what we call the moderator band. The moderator band or moderator band. A cardiac muscle attached between the interventricular septum and the base of the anterior papillary muscles, known as the moderator band. The moderator band picks electrical impulses from the interventricular septum. It picks electrical impulses for contraction from the interventricular septum, and brings them very fast to this anterior papillary muscle, so that they reach at exactly the same time as they reach other papillary muscles. Because if it wasn't there, electrical impulses for contraction will reach late to this papillary muscle, and it means that it will remain closed while others are opening, or it will remain open while others are closing. That is why this moderator band short circuits those impulses and brings them very fast to this anterior papillary muscle, so that all valves close at the same time and they open at the same time. And this moderator band is only located in the right ventricle, and it is one of the distinguishing features between the right and the left ventricle. The moderator band is between the interventricular septum and the anterior papillary muscle on the right. It short circuits impulses from the interventricular septum, bringing them to the anterior papillary muscle, so that they reach at exactly the same time like the other papillary muscles, such that valves close at the same time and they open at the same time, because these papillary muscles will now receive impulse at the same time and contract at the same time and relax at the same time. And it is only located in the right ventricle, and it is the distinguishing feature in the right ventricle. The rough part of the ventricle, which came from the primitive ventricle, you can see these are what we call the trabeculae, the folds of cardiac muscle and endocardium. These folds are what we call the trabeculae. They make the inner lining of the ventricle rough, and that's why I call this the trabeculated part. These trabeculated parts are the ones which came from the primitive ventricle, and the smooth parts are the ones which came from the bulbous cordis. So we have looked at the papillary muscles, how they attach to the valves, how they participate in closure and opening of the valves. We have looked at the inside of the chambers, the rough parts and the smooth parts, and where they come from. We have looked at what auricles are. We have also looked at the papillary muscles on the right and on the left. The ones on the left are bigger, the ones on the right are small. We have looked at what we call the moderator band, which short circuits impulses from the interventricular septum to the base of the anterior papillary muscle. And we have said that the tricuspid valve has 3 cusps and the bicuspid valve has 2 cusps. And principally, that is how the chambers look on the inside. And I've given you enough notes to appreciate that. I've talked about the moderator band, and I've given you the notes about the moderator band. They are going to be helpful for you when you're looking at it. You can see our moderator band coming to the base of the anterior papillary muscle. Because impulses are likely to reach late, if the moderator band was not there to short circuit them, they would reach late, and it will not contract and relax at the same time as the other papillary muscles. Hence, the valve will be, part of it will be open when it's supposed to be closed, and part of it will be closed when it's supposed to be open, and cause that impairment of blood flow. We talked about the walls of the left ventricle and the walls of the right ventricle. And here we are looking at the bicuspid valve and the 2 papillary muscles. And these 2 papillary muscles are, one is attached on the anterior wall and the other one is attached on the posterior wall. And the valves also have the anterior and then the posterior valves. That is for the bicuspid valve. So blood is going to come from the left atrium to the left ventricle through this valve. Left atrium to the left ventricle through the valve which is located there, which is known as the mitral or bicuspid valve. Remember The papillary muscles on the right and the papillary muscles on the right are smaller than the papillary muscles on the left. The same applies to this illustration. So here we are saying that when the papillary muscles are relaxed during diastole, the valves open. They pull the valves open, and blood moves from the atria to the ventricles. And during systole, when they contract, they push the valves closed so that blood does not regurgitate back to the atrium, such that the cardiac output is little. And these are the chordae tendineae, which attach the papillary muscles to the margins of the valves. Now, the next point we are discussing is how do electrical impulses pass through the heart? You have prior knowledge of this, but let us look at it. We are going to look at a specialized cardiac muscle system. These are cardiac muscle systems made up of specialized cardiac muscle cells. These parts of the conducting system of the heart are made up of specialized cardiac muscle cells or specialized cardiac muscle tissue, known as the sinoatrial node. That is where waves of contractions originate from. Remember one thing, that the heart does not need a nerve supply to pump. The heart does not need nerve supply to pump. The heart does not receive its electrical impulses from the nervous system. Specialized cardiac muscle cells known as sinoatrial node cells generate waves of electrical impulses, which are transmitted throughout the heart. That is why if you cut off the nerve supply from the heart will continue pumping, because the waves of electrical impulses, which are going to cause depolarization waves, which are going to move along the muscle of the heart, originate or from the sinoatrial node. Then what is the purpose of the nervous system? The nervous system just controls the rate depending on the oxygen demands. So the nervous system just controls, increases sympathetics when there is increased oxygen demand, decreases when there is decreased oxygen demand. It moderates. Both of them are important. One stimulates, the other one controls. The nervous system controls. Then there is another specialized cardiac muscle tissue known as the atrioventricular node. Then the atrioventricular bundle and its bundles, and we're going to look at this. So when you look at our heart, we go back and orient ourselves. Right border, inferior border, left border, superior border. Right atrium, right ventricle, left ventricle, and posteriorly we'll have the left atrium. Here we'll have the bicuspid valve. Here we'll have the tricuspid valve. Sorry, and this is the bicuspid omitral valve. And somewhere there we'll have the aortic valve, and somewhere here we'll have the these are the pulmonary valves, and these are our aortic valves. These are the aortic valves through which blood passes from the left ventricle to the aorta, and these are the pulmonary valves through which blood passes from the right ventricle to the aorta, to the pulmonary trunk. This is the interventricular septum, interatrial septum. This is the interventricular septum. You first orient yourselves. Right atrium, right ventricle. Left atrium, left ventricle. Right border, inferior border, left border, superior border. Tricuspid valve, bicuspid or mitral valve. Pulmonary valves, aortic valves. Interarterial septum, interventricular septum. Papillary muscles, chordae tendineae. Now, at the junction between the superior vena cava and the right atrium, at the junction between the superior vena cava and the right atrium, we are having the sinoatrial node there. That's where we have the sinoatrial node, creating waves of contraction, which move as depolarization waves. You have seen that when an electrical current is moving on the membrane of cells, it depolarizes those cells. That's how an electrical current moves. So the depolarization waves originate from the sinoatrial node at the junction between the superior vena cava and the right atrium. Now, I want you to appreciate that these depolarization waves first move through the atria, both the right and the left. That is why when the right atrium is contracting to push the remainder of blood into the ventricle, simultaneously at the same time, the same thing is happening in the left atrium when it is contracting to push blood from the left atrium to the left ventricle. Remember, during diastole, blood is coming from the right atrium and the left atrium and is entering the right ventricle and left ventricle simultaneously. And at that time, the ventricles are relaxed and they have expanded to increase the cavity of the ventricles. The first blood which moves to the ventricles moves passively, and the remainder of the blood is pushed by the contraction of the atria into the ventricles. So these are the waves of contractions which are going to help the atria to pump the rest of the blood which will have remained in the atria into the ventricles, that is in the late stages of diastole. It means that during diastole, the atria are first relaxed and blood is moving passively into the ventricles. And then during late diastole, that is when we have contraction of the atria. So contraction of the atria occur during ventricular diastole to empty the remainder of the blood into the ventricles. And these are the waves of contraction. So these waves, when they are released from the sinoatrial node, which is between the superior vena cava and the right atrium, they first move through both the left and the right atria. That is why atria contract at the same time. When the right atrium is pushing blood to the right ventricle, at the same time, the left ventricle is pushing blood to the left atrium is pushing blood to the left ventricle. And because of these waves. So after these depolarization waves have moved through the atria, they converge at the atrioventricular node. This acts as a gateway of these depolarization waves between the atria and the ventricles. This atrioventricular node is also a pacemaker. In its own, but the major one is the sinoatrial node, where everything begins from. And this is at the junction between the interarterial septum and interventricular septum. When these waves of contraction or depolarization reach the atrioventricular node, they delay for some microseconds. Why do they delay for some microseconds? To allow the ventricles to completely fill. Because once these impulses are relayed to the ventricles before they fill, they are going to contract and push out little blood. So they converge at the atrioventricular node, and then they delay for some microseconds to allow the ventricles to fill. Then they are relayed into this bundle of cardiac muscle, known as the atrioventricular bundle, which enters the interventricular septum. Then the atrioventricular bundle divides into a right branch, which is going to take impulses to the right ventricle, and a left branch, which is going to take impulses to the left ventricle. Then these branches divide into finer branches, so that the impulses will reach all cardiac muscle. And these finer branches are the ones we call the Purkinje fibers. And that's how impulses are traversed throughout the heart, through this specialized cardiac muscle tissue sinoatrial node, atrioventricular node, atrioventricular bundle, right and left branches, which arborize into small and fine Purkinje fibers. And remember, the moderator band is the one which is going to pick impulses from the septum and transmit them very fast to the anterior papillary muscle to short circuit them so that they reach earlier. At the same time, they reach the other papillary muscles so that there is no delay. This next part of our lecture is very important and also needs a lot of attention. Very important and also needs a lot of attention. The blood supply to the heart. We know that the functions of blood brings nutrients and oxygen to tissues. That is through arteries, oxygenated, with a few exceptions we saw. And then the waste, carbon dioxide and other wastes, are taken away through the veins. And there must be a balance. If the heart doesn't receive oxygen, it will die off. If the wastes are not drained, it will also die off, because increased carbon dioxide is going to increase the acidity of the blood there and the tissues, and it's going to cause damage. So we are going to look at the blood supply of the heart. I'm going to run through it very fast, and you must be very, 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 very attentive, because we do not have time. I'm going to use this illustration, and you're going to relate it to these others. These others are showing you the same. Okay? What you should remember is the right border, inferior border, left border, superior border. Atrioventricular groove, there are blood vessels there. Anterior interventricular groove, there are blood vessels there. Right atrium, right ventricle, left ventricle. Always orient yourselves before rushing to write whatever you want to write. In order, the great vessels from the superior border, right from the right to left: superior vena cava, aorta, pulmonary trunk. I've talked about what the right auricle is and what the left auricle is. Always orient yourselves. This is the aorta. You can see superior vena cava, ascending aorta, pulmonary trunk. These are the aortic valves. And you know that the aortic valves are between the left ventricle and the aorta. We have the aortic valves. The sinoatrial node is at the junction between the superior vena cava and the right atrium. Now, when blood has entered into the aorta, because blood is pumped into the aorta through the aortic valves, and then it enters the aorta. The first branches of the aorta are the coronary arteries. The first branches of the aorta are the coronary arteries. And coronary arteries are taking blood to the heart. They are two. Remember, the first branches of the aorta are the coronary arteries. The heart first gives itself, because if it is not functioning well, it will not pump. The heart first gives itself oxygenated blood through two coronary arteries. We have the right coronary artery and then the left coronary artery. Those are the first branches of the aorta, the right coronary artery and the left coronary artery. We are going to follow the right coronary artery, then afterwards we are going to follow the left coronary artery, and you must be very attentive. Now, the right coronary artery picks oxygenated blood from the aorta. Remember, this extension is the right auricle. This is the right atrium, and this extension is the right auricle. And you can see that it is hidden below the right auricle. So if you open the right auricle like that, you see the right coronary artery there. Even in the other illustrations, you can see the right auricle here, but you can see deep to it, you have the right coronary artery picking blood from the aorta. Those points look minor, but they can be examined in multiple choice questions. The right coronary artery lies A, below the left auricle, B, below the right auricle, C, below the right atrium, and so on. So as the right coronary artery is originating from the aorta as one of its first branches, it is hidden below the right auricle. But you can see there, we have scanned it to show you that the right coronary artery is originating from the aorta as one of its first branches. Then it will enter the atrioventricular groove, and that is the one of the blood vessels we saw in the atrioventricular groove. Now, after it has originated from the aorta and has entered the atrioventricular groove, it begins giving off branches, and most of the branches are given off to the right atrium and the right ventricle. So let us look at the branches. After originating from the aorta, there are very many branches, but after originating from the aorta, it gives off this very important branch known as the sinoatrionodal branch, and I don't need to tell you what it supplies. It gives off the sinoatrionodal branch, and you see where it is going and you see what it supplies. If this sinoatrionodal artery is blocked, oxygen is not going to reach the sinoatrial node. It is going to die off, and the heart is going to become weak and weak and weak, and it's not going to be able to pump blood well. Because if these cells die of the sinoatrial node because of lack of oxygen, they are not going to generate impulses, and the heart will stop or it become very weak. Why does it become very weak? Because the atrioventricular node also can act as a pacemaker, but this one is the ultimate one. It can't sustain the heart. The atrioventricular node cannot sustain the heart without the sinoatrial node. The sinoatrionodal artery, a branch of the right coronary artery, is very, very important. By the way, what causes death of muscle or death of tissue when oxygen is cut off? You know that oxygen is very important in the formation of ATP. So when we have two types of respiration. We have aerobic respiration. Aerobic respiration is whereby cells of the body manufacture energy using oxygen. That aerobic respiration gives us 38 molecules of ATP. That is somehow good energy, a lot of it. plus carbon dioxide and water which you breathe out. However, in the absence of oxygen, our tissues will tend to anaerobic respiration. Anaerobic respiration is not sustainable because it only gives us 4 molecules of ATP, 2 of which are used and you have a net of 2. As if that is not enough, what are the waste products? Lactic acid. Lactic acid begins damaging the muscles and they die. So our bodies are adapted to aerobic. It gives us enough ATP, 38 molecules, and the carbon dioxide and water can be breathed out, no acid. But if blood oxygen is cut off, the tissue will tend to anaerobic, which will cause death. Accumulation of lactic acid, little energy, death of muscle. Of course, oxygen, those of you who did your biochemistry well, in the process of manufacturing of energy, it acts as the final electron acceptor to take out electrons so that more electrons come through the electron carrying system to produce more energy. But just know it is used in the process of manufacture of energy as the final electron acceptor. You discuss that. So the sinoatrionodal branch is very important. As the right coronary artery continues in the atrioventricular groove, it gives off right ventricular branches and right atrial branches. There are very many. We cannot use all of them, indicate all of them here. And near to the inferior border, it gives off what we call the right marginal artery. This right marginal artery is the largest and runs along the inferior border of the heart. When it reaches the inferior border of the heart, it then goes to the inferior surface, and you can see here it is curving to go to the inferior surface, and also gives off branches to the inferior surface. And one of the branches it gives off to the inferior surface is the atrioventricular nodal branch. Atrioventricular nodal branch. And just by its name, you know what it supplies. It supplies the atrioventricular node. Now, are you seeing how the right coronary artery is important? The right coronary artery is important. Remember, the person who doesn't mute your microphone, the person who doesn't mute their microphone, they are creating an environment for you which is not conducive for me. I will continue. So on the inferior surface, it gives off branches to the ventricles, the right ventricle, and also one of the most important branches it has given off is the atrioventricular branch, which is going to supply the atrioventricular node. It's going to go and supply the atrioventricular node, meaning that the right coronary artery is supplying both the sinoatrial node and then the atrioventricular node. But we have seen it moving from the aorta, giving off that branch, sinoatrial branch, entering the atrioventricular groove, giving off branches to the right atrium and right ventricle, then it gives off the right marginal and the inferior border, then it continues on its inferior surface and gives off branches there, and one of the branches is the atrioventricular nodal branch, which is going to supply the atrioventricular node. The right coronary artery is very important in supplying these two pacemakers. Then it finally gives off a branch. You remember when I was talking about the inferior surface of the heart made by the right ventricle and left ventricle, and in between them there is a groove known as the posterior interventricular groove. You go back to the inferior surface of the heart, you see the posterior interventricular groove. So after giving off all those branches, the right coronary artery will finally give off this branch, the posterior interventricular artery, which is going to pass and enter into the posterior interventricular groove on the inferior surface of the heart. And then this other artery, which we shall see, which will anastomose with the other branches. These are the branches of the right coronary artery, and the illustration is very, very, very clear. It even needs very little explanation. You can look and see. The same illustration is indicated there, and the same illustrations are indicated elsewhere. The left coronary artery moves also and passes below the left auricle. But for it, it is short. Below the left auricle, so this is the left auricle, and you see it's passing below. It divides into two here. This is known as the circumflex artery, and this is known as the anterior interventricular artery because it is passing through the anterior interventricular groove. Then the anterior interventricular artery is going to give off a diagonal artery, which is going to supply the left ventricle. It will continue down the anterior interventricular artery. It's going to give off a diagonal artery. It continues giving off branches to the right and left ventricle. And when it reaches the apex of the heart, the anterior interventricular artery curves and goes to the inferior surface and enters the posterior interventricular groove, where it will anastomose with this posterior interventricular artery, which is coming from the right coronary. The circumflex will go and give off a branch to the left border, on the left border known as the left marginal artery, supplying the left ventricle. Then it will curve and go to the posterior surface to supply the left atrium, because the left atrium forms the posterior surface. And finally, it will go and anastomose with this one. This one is the transverse branch, which came from the right coronary, and they will anastomose. That is the blood supply of the heart. Do coronary arteries anastomose? We can see there the anastomose. But these anastomoses are not sufficient. The purpose of an anastomosis is this: that if an artery is blocked on one side, blood can come through the other side and compensate. However, the anastomoses of coronary arteries are very small, such that if one side is blocked, they will bring in very little blood, which will not be sufficient. What is the importance of that knowledge? The importance of the knowledge is that coronary arteries must always be open at all times. What causes coronary arteries to block? High levels of cholesterol can clog the inside of these arteries and narrow them and block them and cut off blood supply to one part of the heart. That cholesterol is what we call the low-density lipoprotein. It can be a clot which can block those blood vessels, but most commonly cholesterol. And when blood supply to the part of the muscle is cut off, that part of the muscle is going to result to anaerobic respiration. Lactic acid is going to accumulate and it's going to damage that muscle and it's going to die off. And you're going to sense pain on the left chest. Pain on the left chest, because the heart is not sensitive to pain. It's going to transmit that pain on the left chest, because the spinal cord part which supplies the heart also supplies the left chest. So that pain is going to be referred to the left chest and the medial aspect of the arm, and is known as angina. It is an indication that the cardiac muscle is being damaged, and also it is known as, and also indicates that the coronary arteries are being blocked. And in layman's language, they call it heart attack. But the cardiac muscle is dying off due to blockage of coronary arteries. they have to make sure that the coronary arteries are open either surgically or pharmacologically. Otherwise, the heart muscle will die off and someone will die because of heart failure. So these anastomoses are not sufficient. Coronary arteries must always be open. However, before we even look at that, we have looked at the blood vessels, how oxygen reach the heart, how the right coronary and left coronary supply oxygenated blood to the heart. What about the venous drainage? What about the venous drainage? Let's orient ourselves: right border, inferior border, left border, superior border, superior vena cava, aorta, pulmonary tract. So let us look at the veins. Veins coming from the anterior surface of the heart drain directly into the right atrium. So here we are seeing that the right atrium is not only receiving blood from the superior vena cava and inferior vena cava, it is also receiving deoxygenated blood from the heart itself through this anterior cardiac vein. They drain deoxygenated blood from the anterior surface of the heart and take it directly into the right atrium. Then on the inferior border of the heart, what we call right marginal veins. Now, these right marginal veins are the ones which are moving with the marginal artery. They are the ones which are moving with the marginal artery, right marginal artery. So we are seeing the right marginal veins. They are going to drain into another vein known as the small cardiac vein, which is going to go to the inferior surface and drain into a big vein known as the coronary sinus. Anterior cardiac veins drain directly into the right atrium. The right marginal veins on the inferior border, moving with the right marginal artery, drain into the small cardiac vein. The small cardiac vein is going to go to the inferior surface of the heart and drains into the coronary sinus, which is the big vein. And this coronary sinus is the one which is going to drain into the right atrium. So the right atrium also receives deoxygenated blood from the coronary sinus. This one on the inferior surface of the heart. Then there is this middle cardiac vein. The middle cardiac vein is the one which moves with this posterior interventricular vein on the inferior surface. So the middle cardiac vein will also move with the posterior interventricular vein on the inferior surface, and it will directly drain into the coronary sinus. Then there is the anterior interventricular vein. The anterior interventricular vein is the one which is moving with the anterior interventricular artery. That anterior interventricular vein is going to drain into what we call the great cardiac vein. And the great cardiac vein is going to go to the posterior surface of the heart, and it's going to confluence with other veins, and they are going to drain into the coronary sinus. So this coronary sinus is the largest vein of the heart. It receives the small cardiac vein, the middle cardiac vein, the great cardiac vein, and other veins, and it will finally take all that blood into the right atrium. So the right atrium receives the superior vena cava and inferior vena cava blood, blood from the anterior cardiac veins, and blood from the coronary sinus. So here we're looking at the inferior surface of the heart, where the inferior surface of the heart where we have our coronary sinus. Now we have turned to the inferior surface of the heart to see this coronary sinus properly. It's a vein. So here we are seeing it receiving the small cardiac vein. Here it is receiving the middle cardiac vein. Here it is receiving the inferior vein of the left ventricle, which we saw here. Inferior vein of the left ventricle, this one, inferior vein of the left ventricle. It is also receiving these other veins, which are branches of the circumflex, or which are branches of the great cardiac vein. This is the great cardiac vein, which we saw here. Great cardiac vein, this one. And it is also all bringing this blood and pouring it into the right atrium. So the right atrium receives deoxygenated blood from the superior vena cava, inferior vena cava, coronary sinus, and anterior cardiac veins. Coronary dominance. Coronary dominance. We have what we call coronary dominance, which is divided into right coronary dominance and left coronary dominance. Most of our hearts are right coronary dominant. Now, what do we mean by coronary dominance? Let us look at this branch, the posterior interventricular artery. You remember it's a branch of the right coronary. In this illustration, the right coronary comes, goes to the inferior surface, and then finally gives off this from the right coronary, like in this illustration. If your posterior interventricular artery is coming from the right coronary, you are taken to be right coronary dominant. But if it is coming from the other side, if it's coming from the anterior interventricular, you are taken to be left coronary dominant. I repeat, if the posterior interventricular artery is coming from the right coronary artery, you are taken to be right coronary dominant. If it is coming from the anterior interventricular artery, you are taken to be left coronary dominant. Coronary dominance just shows that which artery supplies most of the heart, and this artery is the dominant one, or is the determinant. Where does the posterior interventricular artery come from? Does it come from the right coronary? You're right coronary dominant. Does it come from the left coronary? You're left coronary dominant. I said that cholesterol can clog these blood vessels and block them and cut off blood supply, leading to death of muscle because of deprivation of oxygen. This is low density lipoprotein. That's why we need to check our cholesterol levels, the low density lipoprotein, whether it is out of range, and it is obtained from animal products. So take an example. This is the anterior interventricular artery. If it is blocked there by a cholesterol plaque, which we have seen there, it means that blood is going to stop there. It's not going to reach this other part of the left ventricle. And when blood doesn't reach the left ventricle, you have no problem. So, many times they harvest a vein from the lower limb known as the saphenous vein, the small saphenous vein. Why do they harvest that vein? Because that vein has almost the exact lumen like the coronary veins. And it has few valves. Because if you use a vein in the heart, the valves are going to obstruct. So it has few valves. But even if they have harvested it, they turn it the other way around so that the valves are in opposite, so that they do not block the flow of blood. So they connect that vein to the aorta and then connect it to the other part of the artery after the blockage. So that much as blood is ending there, blood is going to be picked directly from the aorta and will go after the blockage, and it will continue down to supply the ventricle. This is what we call the coronary bypass graft. We are bypassing the blockage because blood is no longer reaching, so you have to bypass the blockage by harvesting a vein and transmitting it there. Sometimes this blood can be tapped from the internal thoracic artery, depends, but this is what you call coronary bypass grafting. But you can avoid it by really having healthy food and exercising and taking low levels of cholesterol from animal products. It is complicated. So there are other interventions. They may not use the grafts. They may insert tubes inside these coronary arteries, and then when the tube reaches the blockage, they pump it and it inflates and it opens the artery wide. You read about the different interventions of coronary artery disease, how they handle it. This is just one example, coronary bypass grafting. The nerve supply to the heart, I talked about it, controlling the sinoatrial node, sympathetics and parasympathetics from the vagus nerve, sympathetics from the sympathetic trunk. Remember, this is the same nerve supply to the visceral pericardium, and that is the same blood supply to the visceral pericardium. Because I remember when I talked about the pericardium, I said that the visceral pericardium takes the same blood supply and venous drainage of the heart, and also takes the same nerve supply of the heart because it is attached to the surface of the heart. Fetal saturation, I think I talked about fetal saturation. Very important, fetal saturation before and after birth. I talked about it, and if you don't remember, you go back and revise fetal saturation before and after birth. These are some of the clinical correlates I want you to go and read about it, about inflammation or injury to the pericardium, pericarditis, and the two membranes of pericardium can constrict or can attach to each other. Pleural effusion, pericardial effusion is excess pericardial fluid. Cardiac tamponade. The excess pericardial fluid can exert pressure on the heart and limit its expansion or its relaxation. Cardiac tamponade. Injury to the muscle, myocarditis, and death of cardiac muscle, myocardial infarction. You're going to go and read about these clinical correlates.